Recording, and we'll make a start. So, thank you very much, all of you, for joining us this week. So, my name is Jack. I'm one of the FY2s that works at Salford. And Twilight teaching this evening, we're going to be talking about headaches. So, it's a really big topic. There's a lot that we can cover today. I'm going to try and keep it as simple as I can. What we're going to talk about is a bit of a run through of the different types of conditions, the different conditions that cause headaches. Going to use a system for classifying headaches and think about how you can group them together. We're going to talk about red flag symptoms, because it's really important for your exams and then also for your working life to know when to suspect something other than an innocent cause for headache. And we're going to talk a little bit about data interpretation, CSF sampling in this case, and then there's just a few MCQs at the end in order to test your knowledge a little bit. And I've got a Kahoot quiz, so if you could all have like a phone or a spare device handy, that'd be really helpful. Whilst I'm going through, there's probably going to be quite a lot of information coming at you, because the first part of the teaching is on the different kinds of headache. I don't want you to write anything down because we're recording this. What I want you to do is just pay attention, and I'm going to ask you to message in the chat at a few different points, because what I've done is put some information or omitted some information from the presentation, and at the relevant points what I'll ask you to do is just give me some suggestions. So what I'd like you to do is just type in the chat a suggestion, come up with a few things, and once I've got a few answers, see that you're engaging, hopefully not nodding off, then we'll move on. Okay, so we're going to start off by running through just a few basic questions about why do you need to know about them. So why do you need to know about headaches? Because it's a really common symptom. There are loads of different conditions that present with headaches, and some of these conditions are life-threatening. There's a lot of morbidity and mortality associated with a number of things that cause headaches. And on a more cynical level, this topic will come up in exams for those exact reasons. Common conditions and life-threatening conditions are the kind of things that the medical school will test you on. So there are some things that you need to know really well amongst the topic of headaches. So what do you need to know? The common presentations, the emergency presentations. You need to know the red flag symptoms that suggest emergency presentations. And you should know a little bit about how you investigate and manage those above conditions. And let's move into the sort of teaching topic. So how do we classify headaches? The way that the International Classification of Headache Disorders classifies headaches is like this: primary headaches, secondary headaches, and neuropathies, facial pains, and other headaches. And as we go through them, we'll talk a little bit more, but basically primary headaches are headache disorders with no underlying cause. They're not associated with an underlying condition. Secondary headaches have something that is causing the headache in particular. So things that could be causing secondary headaches, things like stroke, things like intracerebral haemorrhage, things like a brain tumour. Those are the kind of things that are secondary headaches. And then neuropathies, facial pains, and other headaches are not headaches in a purist sense, but patients don't always give you a classical history, and it's up to you to try and work out whether that headache they're describing is actually more of a facial pain and that kind of thing. So we'll talk about all of the headaches in the primary headache category, because it's important to know about them. We'll talk about a selection of the secondary headaches, and there's quite a lot to go through. We're only going to touch on them briefly, but it's still going to take up quite a lot of time. And then finally, we'll just talk about the main one in neuropathies, facial pains, and other headaches, because you can really get down into small print for each of these, but As I've said, for your exams, particularly at the stage you're at, what you need to know about are common things and life-threatening things. So those are the things that we're going to really cover today. Okay, so primary headaches are migraine, tension type headache, and cluster headache. Headaches that aren't associated with an underlying condition. So these are headaches that people can develop, and we're going to talk about how they present, how you investigate them, how you treat them. Okay, so migraine. The migraine headache has a very classical history. Not all headaches that are migraines present in this classical way, but there's a very nice set of criteria that if you look on NICE CKS, you'll be able to find. Classical history is this unilateral pain. It can be moderate to severe, and it has associated symptoms. So, can you tell me what some of those associated symptoms are that you see with migraine? What are the kind of things that somebody might complain of if they had a migraine headache? Nausea, yeah. Auras, good. Visual disturbances. Yeah, great. Yeah, so these are all things that somebody with migraine might describe. So let's have a look at some of these associated symptoms first. So nausea, vomiting, photophobia, phonophobia. So people tend to feel a bit sick and they don't like bright lights and loud noises. So they tend to go and have a lie down, and that runs into this sort of typical presentation. So you get this unilateral pulsating headache, and it interferes with normal activity. So people need to go and lie down in a dark room because they don't like sounds, they don't like lights, they can't do what they would normally do in the day. So often you'll hear people describe, and you say, when you're taking a history, you say, tell me about your headache, or just tell me what's been going on, and they'll start speaking, and they'll often say to you, like, I can't get on with the day, have to go and have a lie down. And if you hear that, definitely migraine should be something that you're thinking about. This lasting 4 to 72 hours, so it's quite a wide range, but as you'll see, there's a lot of durations of headaches that you come across. So not really shorter than this. And obviously, if it's going constant, if it's a headache that's been constant for a week, again, it should make you think about other things. This aura that a few of you guys have mentioned, so that is, I'm going to try and pronounce this right, so the visual changes of aura, one factor, and that can be scintillating scotoma, which is, some of you may well get migraines and know exactly what I'm talking about, but it's kind of a jagged, like shimmer almost in your vision. If you Google it, you'll be able to get sort of visual interpretations of exactly what it looks like. Kind of zigzag lines in your vision. And this aura comes on in the run up to a migraine. So you can, some people have a prodrome that starts sort of days before the migraine comes on. An aura happens within an hour of the migraine. That's part of the diagnostic criteria, is that it needs to happen within an hour of the headache coming on. People can have numbness and tingling, pins and needles in their hands and legs. Tends to be down one side as well. So typical presentation of migraine, unilateral headache, and an aura would tend to be unilateral as well. People may have speech disturbances as well with an aura. So they may have dysphasia or slurred speech. Obviously, with something like that, you need to be able to tease apart whether or not this is stroke. And if in migraine, what's going to happen is in an aura, that'll happen and it'll resolve and somebody will start getting the headache and these aura symptoms go away. But obviously with stroke, if somebody has slurring of speech and they don't have a headache, that could be a stroke. And if they have slurring of speech and it's still there when the headache's present, that should also be making you think about stroke. Basically, with migraine, this is a recurring acute episodes, and you need to look at these kind of things, so unilateral, pulsatile, nausea, vomiting, and tease that out from the history. There isn't a diagnostic test that's going to prove that somebody has migraines. It's about taking a good quality history, letting the patient tell you about that aura that they have or don't have, and diagnosing in somebody that doesn't have aura is slightly different. It goes more on these characteristics that we've mentioned here that allows you to diagnose it in those cases. Management, though, is same between migraine with or without aura. Can anybody tell me some ways of managing a migraine? What treatments do we use? Sumatriptan? Beta blockers, yeah, good. NSAIDs, antiemetics, yeah, good. So there's a few different things that we use to treat it. So what you do is ask somebody, if there's any doubt in your head, what you should be doing with a lot of these types of headache is, if you haven't got a classical history, get somebody to take a headache diary. So if somebody says, I've got a unilateral, pulsatile, throbbing headache, I feel sick when I have it, I have to go and lie down, I get this funny feeling in my arms before the headache comes on, and then my day's ruined and I have to go to bed. You can be pretty sure that's migraine. So what you could ask them to do is just keep a diary, a headache diary of things that may be setting this off. Is there any relation to the time of day, whether they're at work, what they've had to eat, what exercise they've been doing? Because people will sometimes be able to identify triggers that set off headaches. And if you can identify triggers, you can try to avoid them. It's not always possible. Obviously, if stress is a factor in setting off people's headaches, then it's not always possible. You can't just pack up your job and move to something else. But it can be helpful for people who identify certain foodstuffs or certain activities that might predispose them to having a migraine. When we come to management pharmacologically, it breaks down into acute relief and prophylaxis. Acute management is with, as some of you have mentioned, with things like simple analgesia, first of all. So it's paracetamol, it's ibuprofen, and you can also use big doses of aspirin. So the aspirin doses that you might know for secondary prophylaxis of MI is a sort of 75 milligram dose. And then you have like your sort of 300 milligram loading doses. The analgesic dose for aspirin is 900 milligrams, so it's a big dose. You wouldn't want to be giving that to somebody who has got potential bleeding risks. But it is very good, actually. Aspirin at that dose is very effective at relieving migraines. You can then move on to oral sumatriptan if your simple analgesics don't work. And antiemetics, interestingly, even if somebody doesn't have nausea or vomiting as one of the symptoms of their particular migraines, antiemetics can be beneficial in reducing the symptoms. There's been research that has shown that people with migraines tend to have an element of gastroparesis, so stomach slows down, which can contribute to nausea and vomiting. And antiemetics can help with that. So the antiemetics that we tend to use are metoclopramide, which is a prokinetic, and prochlorperazine, which is Bucostem. It's the tablet that goes under the tongue. Both of which can be really good at treating nausea, but also in people who don't even have nausea, it can be helpful at making the pain relief medication more effective. You can also use preventative medications, and this is where your propranolol, so Hannah's mentioned beta blockers, topiramate and amitriptyline come in. Again, you need to think about particular contraindications. If somebody has a history of asthma, you might be less inclined to give them propranolol. But you move on to prevention only if acute relief isn't working. And we'll talk about why prevention can be useful, because we'll talk about one of the secondary headaches, which is medication overuse, a little bit later on. So with migraine, this is your typical picture. This is how you manage it. You can try and identify triggers. You've got acute relief, and then you've got preventative medication. Is everybody happy with that? If you've got any questions, please put them in the chat, but I'm going to move on to the next type, which is tension headache. So this is a really common kind of headache. You've probably all had it. Most people will have them from time to time, and when it's becoming a regular occurrence is when people tend to go to the doctor about it. So this is the headache that is bilateral. It feels like a tight band. It lasts anywhere from a few minutes to a few days. One of the things that sets it apart from migraine is the fact that you can usually carry on with your day. Migraine is pretty disabling if you've ever had one. But with tension headache, it's kind of just gnawing away in the background. You can get on with what you're doing. It just makes things a little bit more of a bother. You don't tend to have nausea or autonomic symptoms with it. People won't complain of visual changes or anything like that. Again, history is key. So make sure that you're really getting an idea of the character of people's headache. Feel like you're getting to know the headache a bit better. Management for tension headache, again, if they're in a stressful job that causes these headaches, that could well be contributing. Just see if you can identify factors. Again, a headache diary is something that you can recommend to people. If you're in an OSCE and you're taking a headache history, something to offer in a management plan is a headache diary. Even if you're certain of the diagnosis, if you think this is barn door tension headache, say to someone, this is what we're going to do for you today. So what you need to do is take paracetamol as soon as the headache starts. It's an important point to mention actually for migraine. So these acute relief medications, if you're advising somebody when you should take it, because they might have aura and they might think about taking it then, it's when the headache starts, when the pain starts, rather than when the aura comes on. So that's when they need to take their acute relief. So in this case, if they're taking simple analgesia, take it when the headache comes on. If frequent use of headache relief is becoming a problem, you can start using amitriptyline for prophylaxis. And opioids have no indication in tension type headache and can often cause more problems than they solve. So, cluster headache. So this is the third and final type of primary headache. It's a rare condition. It's more common in men, a lot more common in men than in women, and typically presents in youngish men as well. It is disabling. It's really debilitating. If somebody tells you about a history of unilateral pain around the eye and it's totally manageable and they're going about their day absolutely fine, it's probably not going to be cluster headache. Cluster headache is like life-ruiningly bad. Like, people have these clusters of headaches, so they come in these attacks that are discrete episodes, but the episodes have a recurrence over days and months, lasting up to a year in some cases, and then they will tend to go away for a month or more and then will often relapse. When these attacks are occurring, people are distraught, they're depressed, increases the risk of suicide because they're that disabling. you tend to get these ipsilateral autonomic symptoms that say around the same eye. So do any of you know some of these symptoms that you see typically with cluster headache? So we're talking about things like redness of the eye, tears, feeling of stuffiness, get a runny nose, get puffiness of the eyelid, you get swelling of the face and flushing. People basically, like, people look a state. They'll be pacing erratically, they'll be restless. Whereas with like migraine, they want to go and lie down in a quiet room. With cluster headache, when they're having an attack, they won't be able to sit still. They'll be like, often you just hear people describe banging their head against the wall to try and distract from the pain. They will be really sort of upset whilst these headaches are going on. When you're investigating it, you might have a really nice history. They need to be referred to a specialist at their first presentation. If they've been diagnosed by a specialist with cluster headache, recurring episodes can be managed in GP, but they need to be referred to a specialist for assessment in the first place. And management, does anybody know how cluster headache is managed? High flow oxygen, yes it is, yeah. And triptans, yeah, very good. So importantly, it's subcutaneous or nasal triptans. So oral triptans don't have a role in the management of cluster headache. So triptans are used for migraine, oral triptans, but they're not used here. It's subcut or nasal, and high flow oxygen as well. Okay, so we have got loads of secondary headaches. I'm going to try and get through them quickly. And what I'm going to do on the way through is highlight some red flag symptoms, and it's going to be relevant for some questions at the end, and obviously also for your learning. So first of all, stroke. So a lot of these are going to be covered in other areas of your curriculum. So don't get too bogged down in exactly how we manage, how we investigate all of what we're doing. Basically, have in the back of your mind, if somebody comes in with a headache, what are the questions that I need to ask to determine if it's one of these? And if I think it's one of these, what am I going to do to investigate it? A headache could very easily be a station in one of your OSCEs. So what you should be thinking whilst we're going through all of these secondary headaches is, what are the questions that are going to differentiate a primary headache, which I might be less worried about, from a secondary headache, which may need specialist input, may need further imaging. It may make me a little bit more concerned. So, stroke. Here we're talking about ischemic stroke, and then we'll talk about the types of intracranial hemorrhage that cover the hemorrhagic strokes. So you get infarction of the cerebral circulation, and you get this rapid onset of CNS symptoms, and these tend to be irreversible. If they do reverse, then you might be dealing with a TIA, or it could be, as we mentioned, it could be part of that migraine aura. Differences with a TIA, they won't tend to have a pounding headache. So we're going to talk about some of the risk factors for stroke. Can you guys tell me just very quickly some risk factors for stroke that you know? Yeah, oral contraceptive pill, very good. Hypertension, yeah. Yeah, family history, smoking, AF. Anticoagulants wouldn't be a risk factor for ischemic stroke, but certainly for any kind of intracranial hemorrhage, which we'll come on to. So these are just a selection. There are loads and loads of different risk factors, but these are some of the big ones. So high blood pressure, smoking, diabetes, cardiovascular disease, previous stroke, atrial fibrillation, all of them risk factors for having a stroke. Stroke can cause a headache. It's not the most common cause of headache, and not all strokes present with a headache, but it's something that you need to be aware of, particularly if you see somebody who has a headache and this rapid onset of CNS symptoms. Do a CT to rule out a hemorrhage. So if you can see this CT here in the corner, this is an ischemic stroke, and somebody has infarcted probably their MCA, so their middle cerebral artery, just judging by the area of the ischemia, potentially their total anterior circulation, actually, because of the front and middle sections that are infarcted. But I don't know if you guys have seen many CTs before. When you're interpreting a CT, you're looking up from the bottom, and this will be the right side and this will be the left side. So this person will have infarcted a large portion of their left cerebral hemisphere. So what we would be expecting is right-sided weakness of the arms and to a lesser degree the legs in this patient. And then to manage that, we would give antiplatelets, and if we're in the window, then we can do thrombolysis. If we're somewhere suitable, which Salford Royal happens to be, they offer thrombectomy there as well. And if you have seen a patient that has had a thrombectomy, so that's clot retrieval, the results are really dramatic, actually. If somebody gets to have a thrombectomy in time, you need to usually be a good candidate for it, so have a good functional baseline, because it's a risky procedure, but the results are really staggering, actually, and people can basically go back to exactly how they were. They can come in with really significant weakness and fish the clot out, and they'll be basically back to normal. So if people can have thrombectomy, then it's a really good thing to offer them. Sub-arachnoid hemorrhage is a really, really important differential for headache because it's got really significant morbidity and mortality. So when we talk about emergency presentations, this is right up there for being one of the most important. Typical things in the history: it's a sudden onset, worst ever headache. So some of you might have heard like thunderclap headache in your histories. People describe it like being kicked in the head or hit in the back of the head with a cricket bat. And it typically is occipital, so back of the head. They will often vomit. I haven't highlighted that in red because vomiting can be associated with migraine as well. Things that are going to set this apart again are people collapsing, having seizures, reduced GCS. Those are all going to point towards something more serious going on. Risk factors, so trauma. Trauma is the most common cause. So subarachnoid hemorrhage, at medical school, you learn the fact that polycystic kidney disease gives you beryaneurysms, and that gives you a much increased risk of subarachnoid hemorrhage, which is true. 85% of spontaneous subarachnoid hemorrhage is due to beryaneurysms, of which a large proportion are down to people with polycystic kidneys. So 85% of spontaneous subarachnoid hemorrhage are beryaneurysms, but more than 50% of subarachnoid hemorrhage is caused by trauma. So just bear that in mind. A lot of the questions you're asked in medical school are about spontaneous subarachnoid hemorrhage because it's often more about those patients need a little bit more teasing out. If somebody has a history of trauma, i.e. they've fallen off a bridge and fallen onto their head, you're going to be thinking about subarachnoid hemorrhage. They're going to get a head scan and it's going to be picked up. Whereas somebody who is happily minding their own business, that needs a little bit more insight, a little bit more diagnostic reasoning in order to work out. So the things that you're looking for, these kind of features, worst ever headache, potentially some of these features, collapsed drowsiness, and it causes meningism as well, or it can cause meningism at a later stage. So That's neck stiffness. The irritation of the meninges makes people's neck stiff. Koenig sign. So if you tuck one of their legs, if you tuck both of their legs up towards their chest and then let one down, they won't be able to fully relax the leg that you let down. And focal neurology, you may see that if somebody has had a subarachnoid hemorrhage down to increased intracranial pressure can lead to focal neurology. Investigation. So how do we look for subarachnoid hemorrhage? What are we going to do in order to make that diagnosis? CT, yeah. Yeah, good. So CT picks up 90% of subarachnoid hemorrhages in the first 48 hours. Or roughly that's the numbers that I found from the Oxford Handbook. So there's a few people that it's not going to be picking up. 90% is not fantastic as sensitivity. So for people that present with this kind of typical history and they have a negative CT, they're going to get a lumbar puncture, provided that there's nothing stopping them from having a lumbar puncture. And we'll talk a little bit more later on about what things prevent you from having one. But you do a lumbar puncture and you look for xanthochromia. So xanthochromia is just a fancy word for the breakdown products of blood. We do this 12 hours after the onset of the headache. There's a reason that you don't look for blood, and it's because when you do a lumbar puncture, you're putting a needle into someone's cerebrospinal fluid, into the spinal column. By doing that, you can cause bleeding. So if you're looking for blood, you may have just put it there yourself. The reason you look for xanthochromia is because by doing the LP, you won't have those breakdown products there unless there has been bleeding about 12 hours before. So if the CT head is negative in somebody that you suspect of having subarachnoid hemorrhage, then at 12 hours post headache, you move on to doing a tap in anybody with that kind of history. Anybody that you suspect gets a lumbar puncture, provided that there's no reason that they can't have it. Then if you confirm it, what you want to do, you can get really down into the details of how you manage this, but basically give them lots of fluids. If they've had an aneurysm, you want to try and protect that. So until it's protected, you don't want their blood pressure to be above 180 because you risk causing further bleeding, further damage. So you want to maintain a blood pressure of a reasonable amount in order to make sure that their cerebral perfusion is maintained, but you don't want to risk further bleeding. And this nimodipine, 60 milligrams, 4 hours, what that's doing is dilating the vessels and making sure that blood is still flowing to the brain. You don't want to see cerebral vena constriction, because that's when you start getting neurology and you start getting sort of low-level brain damage. So give them lots of fluids, make sure that they're perfused, but you're not risking further bleeding, and make sure they're nice and dilated by using nimodipine. It reduces the chance of cerebral vasospasm. Okay. So those are some of the figures that we've just talked about. This is what a subarachnoid hemorrhage looks like. So you can see that here on CT, this hyper-enhancing region, we're a little bit lower down the head, so a little bit closer to the neck on this slice. And you can see all of this white stuff is blood, and that's just pooling in some of the fissures of the brain. And that would be evidence of a subarachnoid hemorrhage. Okay, so subdurals. The typical history for these is bleeding caused by a deceleration injury. It can be really tiny, actually. People can have quite a small knock, and those bridging veins tear, and often they can happen quite slowly. You get this slow bleed that causes a gradual rise in intracranial pressure, And these are the kind of symptoms that they might present with. It can be ages, it can be weeks after the initial injury. Fluctuating consciousness, drowsiness, personality changes, that's a red flag symptom that we've not mentioned so far, and like unsteadiness as well. So there are a few key risk factors for subdural hemorrhage. Can you guys tell me about any of those? A few people that if an exam question mentioned it, you'd be thinking, oh, this might be a subdural. There are a few key groups that are very at risk of this kind of head injury. Yeah, the elderly's one. There's two more that I'm thinking of. Not babies. Elderly's one. Haemophiliacs, yeah, along those lines. So yeah, people that are on anticoagulation. And yeah, chronic alcohol use. So those are the kind of categories. If you saw somebody with these kind of symptoms, and it would be perhaps an elderly person that was found on the floor a few weeks ago, maybe had a CT head on an initial admission and was fine at the time, discharged, but then has gone home and has started being quite drowsy, or personality changes, maybe they become quite aggressive, but they come back in, that might make you think, oh, this is perhaps a subdural. Or somebody with alcohol abuse has been found in the street, might be considering, have they taken an overdose, but always be thinking as well, could it be a subdural? These are the kind of categories that exam questions will talk about when they want to test you on subdural. And the way you see it is for CT, and that's what you get. You get this concave, so it's dipped in around the surface of the brain. So you get this concave abnormality on CT, and what you're going to do is basically call the neurosurgeons about this, and I'll tell you what to do. Subdural hemorrhage, we just talked about that. Extradural hemorrhage, that's the next one. So the classical history for an extradural is injury to the middle meningeal artery, which causes arterial bleeding. So what you tend to get is blow to the side of the head, and this lucid interval is classic. So you've got an arterial bleed, and initially that won't be a problem. So maybe they'll get hit in the side of the head, probably quite hard, and they'll probably be okay for a bit because that blood hasn't built up enough of a mass effect to start causing problems. But quite quickly after that, they're going to have an absolutely pounding headache, and they might be sick, and then they're going to start becoming less alert, might become confused. These are really serious because arterial bleeds, they need management, really. If you don't recognize it and treat it, then they're going to start getting mass effect. They're going to get midline shift. It's going to lead to coma, and it could lead to brainstem compression and death. So history again is like typical. Also, you're going to see the knock on the side of their head. I'll show you this CT. You can see the convex nature of the extradural. You can also see the lump on this guy's head where he's been hit. You've got midline shift here. This just looks really nasty, and so this is an emergency. Should be quite obvious from the history that this is what's going on. And again, it's going to be a case of calling the neurosurgeons, vascular as well, and just getting them to sort out. Okay, so cerebral venous thrombosis, little bit less urgent than sub-arachnoid hemorrhage and extradural. It tends to be more of an insidious onset. You can get thunderclap headache, like subarachnoid hemorrhage, just to make things confusing, but the onset of symptoms tends to be a bit slower. So people might have this kind of sort of subacute, ongoing, worsening headache that comes on over sort of days to weeks. And you'll see these kind of symptoms again. A lot of the symptoms that we're talking about with some of these more serious causes are similar. Like if somebody's confused, if they've had seizures, if they've got focal deficits, you should be thinking away from migraine and tension headache and cluster headache, and you should be thinking about some of these more serious causes. So cerebral venous thrombosis, a clot in the venous system of the brain. Can you name me some risk factors for developing this? Who are the kind of people that would get venous sinus thrombosis? So it's the same kind of people that get any kind, the same kind of people that get any kind of venous clot. So pregnancy is a risk factor, head injury, being dehydrated, having any kind of malignancy, whether it's in the head or otherwise, tendencies to clot, and intracranial infection. So these are all things. Basically, if you think about what causes DVTs or PEs, it's the same thing, but just going on in your head. So an infection in your head is going to put you at risk, as are all of these other things. CT head is not great at picking up a venous thrombosis, but it is good at ruling out subarachnoid hemorrhage. You want to think about lumbar puncture in these people, and a CT venogram is the diagnostic test really, in order to determine what is going on. You'll normally only come to this point once you've ruled out other more obvious causes of some of the symptoms that are going on. This tends to be a diagnosis that's come to a little bit later. And the way you manage it is with low molecular weight heparin. It may be that you can do thrombolysis in certain demographics of patients. You don't really need to know too much about how it's managed, because again, it's a neurosurgery thing. Okay, so brain cancer is a really important kind of headache to know about. We're going more towards the chronic end of the spectrum here. So what are the kind of symptoms that you might expect from a brain tumour? There's a few that I've got noted down, so chuck some out there. Talking about a mass in the skull, which has only got a fixed volume. What are the kind of things that you'll see with a brain tumour that might suggest that rather than, say, intracranial hemorrhage? Worse in the morning. So signs of raised ICP. So worse in the morning is definitely one of those. Yeah, so these kind of things. So again, nausea and vomiting can be quite a prominent one. Raised ICP. So these are the kind of things that might present first. So somebody might have these sort of headaches that when they wake up are really bad, but then they tend to get a bit easier once they're up and moving around. And the reason for that raised ICP being worse on waking, when you stand up, like gravity, simply enough, gravity just takes pressure out of the head when you stand up. So the reason why in raised ICP, standing up makes the pain better, the symptoms better, and in low ICP, standing up makes the headache worse, is because you're just exacerbating the problem in low ICP and making it better in raised ICP. Seizures are a common late stage sign. Personality changes can happen. And then with these kind of things, it's that progressiveness. So this is a tumour that is growing. That's why it's causing symptoms. It's growing probably quite slowly, but it's not getting any smaller. So problems just tend to become more and more prominent. There are exceptions sometimes. So you do see cases of people that have tumours in a location where it may sort of shift. Like, for example, if it's partially obscuring the outflow of CSF, then you might see changes that get better and get worse because the tumour might move with your movement. So releasing that CSF through, but generally what you're looking for is progressive symptoms with brain tumours. Ask about weight loss, not because necessarily the primary brain tumour might be causing weight loss, but if it's metastatic spread, you're going to be expecting somebody to have weight loss symptoms. So the kind of things that tend to metastasize to the brain, lung cancer is a common one. I think that, what are the other sort of common things? I think that prostate cancer tends to metastasize to the brain as well. And those secondary tumours are much more common than primary CNS tumours. CT head, useful as a screening tool. Might pick up edema. You don't tend to see CT isn't isn't high definition enough to often pick up the tumour itself. If you're suspecting it, you may need an MRI brain in order to diagnose it. And with management, just get them seen by a specialist within 2 weeks. Meningitis. So this is another really important cause of headache. There are loads of different causes of meningitis. The ones that you need to know about, a little bit about all of them. We'll talk about CSF sampling to diagnose meningitis, but basically any kind of infection can cause an infection of the meninges. It could occur to anybody, but the two biggest peaks are children less than 2 years old, and then there's a second peak in teenagers and young adults sort of going away to university again. The early signs that you present with, you get headache, you get aches and pains, fever, lethargy. So you're getting general infective symptoms. If you're diagnosing meningitis at this point, you are bloody good because they're really non-specific. The signs that you get later that tend to lead to people being diagnosed: meningism. So the clue's in the name, meningitis causes meningism. So your Koenig sign, which we talked about, and Brzezinski's sign, which is not being able to flatten out your back when you tuck up. Those are likely to be positive. You get this change in GCS. Seizures can happen. You can develop focal neurology, and this non-blanching petechial rash. So in most cases of meningococcal meningitis, you see this, but there are lots of causes of meningitis that aren't meningococcus. So this is a good question when asking about meningitis, but just because they don't say that they have a rash doesn't mean that isn't the diagnosis. If you're seeing these kind of things, don't get bogged down in this meningitic rash. So let me have just a look here. I've got some notes. So the most common cause of meningitis in adults is not meningococcus, it's pneumococcus. In cases of meningococcus that cause meningitis, you get about 15% that cause the meningitis symptoms without causing septicemia, so the peripheral circulation infection. About 25% of people infected with meningococcus get meningococcal septicemia without meningitis, and 60%, so the biggest proportion, get meningitis and meningococcal septicemia, i.e. the thing that causes that rash. So it's useful. You get 85% of people that have this infection get this rash, but it's not perfect. You need to be aware that if somebody's got this history of like feeling a bit icky a few days ago and now they're meningitic and they've got a fever now, think about all these kind of things. Investigation, so blood cultures, you want to try and find what's going on. Lumbar puncture, which you can do, as it says here, if they don't have any symptoms of focal neurology or signs of raised intracranial pressure, you can do a lumbar puncture. In Salford, for example, they'll probably just have one before you get the chance to do their lumbar puncture. They're very good at CTing people. Lots of A&Es will be able to get the CT done before you get the chance to lumbar puncture them. We'll talk a little bit about the exact specifics of that a little bit later on. In the community, Ben Pen, if you're in the hospital, follow the hospital's policy. It's typically, if for the sake of your exams, it's going to be an IV cephalosporin. Just make sure they're not penicillin allergic because this has cross-reactivity. A history of a rash to penicillin is not enough to stop them getting this, because this is the best antibiotic for treating meningococcus. It's a notifiable disease, so Public Health England need to know about it, and close contacts of somebody with this or this kind of meningitis is going to need prophylaxis and vaccination themselves to stop them from becoming so unwell also. Encephalitis is a little bit more mysterious. Tends to be caused by viruses, but can also be caused by spreading bacterial infection, by TB, by malaria, by cryptococcal infection. But with encephalitis, the organism most typically responsible is these kind of viruses. It's an infection of the brain tissue itself. Odd behavior, reduced consciousness. Again, all of these red flags and all of these things that make you suspect that the brain is being involved in this headache in some way. Things that you need to do: cultures, lumbar puncture, EEG. EEG is going to look really weird, so that will suggest that there's an infection of the brain. It doesn't tell you exactly what's going on, but in a picture of all of this with somebody that's had like a recent sort of infectious prodrome, that points towards encephalitis. And what you need to do is give them acyclovir. You're also going to give them IV cephalosporin as well, because you want to cover for bacterial infection, and they'll be going to ITU because without the proper support, even with the proper support, most of the people that have encephalitis die, unfortunately. It's a very, very serious condition. Cerebral abscess. So again, this can present quite chronically. People tend to have these features of raised ICP. They can be precipitated by infections sort of anywhere around the head, fracture of the skull, endocarditis. So you think if there's an infection in the bloodstream, the brain requires a lot of blood flow. It may well be if they've got endocarditis that they could develop a cerebral abscess. Kind of people that you suspect this in most, but not all, is people with immunosuppression. So things like HIV, TB, IV drug users, that kind of thing. So be aware if they've got features of a raised ICP and they're febrile, they have a raised white cell count, have a high degree of suspicion for this kind of thing. Management with antibiotics and neurosurgery opinion. Acute glaucoma. So this is an ophthalmic emergency. I know that you guys, I don't think you guys cover the eye this year. It's more next year, I think. But this is something that you'd be expected to have a passing knowledge of because of the fact that it can be confused for other things that you do need to know about. So like headache, people will get, the location of pain is very similar to cluster headache, but the character is quite different. So that they get pain in and around the eye, but it's not the most severe pain ever. It doesn't last. So cluster headache tends to last just a couple of hours and then goes, whereas this will ramp up and then it will stay there. What happens is the the portion of the eye. So the eye is constantly making aqueous fluid to sit in the eye and constantly draining aqueous fluid away. What happens in acute closed angle glaucoma is the drainage point gets blocked off, and that means that you're pumping fluid in but not draining it out. So the intraocular pressure is going up and up and up. And as you can imagine, this is really, really painful eventually, and also puts your optic nerve at risk of permanent damage. So the reason why this is an emergency is not just because of the pain, but because it can put you at risk of blindness. Your pupil becomes fixed and dilated in acute closed angle glaucoma. The increase in intraocular pressure makes the eye feel hard, and it's like described as like rock hard. If you push your own eye now, it's kind of squidgy. And in glaucoma, it's absolutely rock solid. And what they get is nausea, headache, vomiting. They get a red eye that is a painful red eye, blurring of vision, and then this is the sort of classical halos around lights. These people need to go to eye casualty, and they need to have these drops put in. Don't worry too much about them. Basically, they just need to be treated urgently, and they should avoid dark rooms or eye patches because of the location of where this drainage point that's become blocked is. Dilating the pupil makes it block even more. What you want to do, the point of all of these drops, is to constrict the pupil, which is going to help that point open up, and they also reduce the production of aqueous fluid, so they're reducing the inflow that's causing this rise in intraocular pressure. So don't need to know loads and loads about the exact pharmacology of treating it, but know that this is an important differential for that kind of temporal periorbital headache. And if you suspect this, if they've got things like halos around lights or a fixed dilated pupil, think about glaucoma and think about sending them to eye casualty. Giant cell arteritis. So again, this is a temporal headache, closely associated with polymyalgia rheumatica, which you may or may not know a little bit about. Rheumatological condition, not very well understood. It causes pain and stiffness in the proximal muscles. Most people who develop giant cell arteritis have polymyalgia rheumatica, so keep an eye out for that in history. It's going to be old people that present with this. They have this headache that also comes with scalp tenderness, jaw claudication, so on chewing, they start getting pain. Won't be there straight away, and we'll talk about how this is different from a different kind of headache later on. Amaurosis fugax, which is like a curtain coming down in your vision. So your vision, you get blacking out like a falling curtain. That's amaurosis fugax. That's really typical. If somebody describes that kind of thing, you need to be thinking giant cell arteritis, and also sudden blindness. This is an arteritis. It's a vascular condition, so the problems happen very suddenly like this. If they're developing this kind of thing, it's going to make you think about giant cell arteritis. They're going to need an ESR, which is going to be probably high, although not always. If they've got a history that fits with it, you start them on pred, because they need to be on high dose steroids in order to reverse this, and they're going to be on them for a long time. You take a good history and you elicit these kind of symptoms that make you think about this, start this, and then worry about follow-up investigations after that. These are really important as well, the PPI and the bisphosphonate, because being on high dose steroids for a long time has its own set of risks. So you need to manage the side effects as best you can. Because in elderly patients, you could make them very unwell by just giving a high dose steroid without any kind of protection. Hypertension is another cause of headache. So talking specifically about malignant hypertension, which is down to a rapid rise in BP. The kind of blood pressures that you're thinking about that cause headache are more than 200 over 130. You'll see retinal hemorrhages and exudates and papilledema. I'm sorry, I've actually forgotten to put photos into this, but again, it's more of next year thing, knowing about your more of your specialty year, needing to know about fundoscopy. But basically what's happening is small blood vessels in the back of the eye are bursting because of how high the blood pressure is. So understandably, you might have a headache too. Sorry. Visual disturbance. So this is the red flag symptom that you're going to be thinking about. Basically, if you're seeing this person in GP and they've got a pounding headache and visual disturbances, it's really easy just to do set bobs. If you see this blood pressure, you're going to be thinking, well, we need to get that blood pressure down. What you want to try and do is bring the diastolic blood pressure down to under 130. If they need to be going to a hospital, ideally for this blood pressure, get them in a monitored bed with or without an arterial line, and these are the kind of agents that you're going to use in order to just titrate that blood pressure down. You don't want to drop it down rapidly or drop it way beyond this, because you're risking problems of, you can put them at risk of stroke in that situation. But just be aware that blood pressure itself can cause an absolutely pounding headache. Raised CSF pressure. So we talked a bit about those symptoms. It's worse on waking, lying down, leaning forwards, coughing. Anything that's going to increase the return to the head is going to worsen a raised intracranial pressure headache. Can any of you name me some causes of raised intracranial pressure? We've already talked about a few throughout the presentation, so should be able to name a couple. Tumour, yeah, absolutely. So we've talked about a tumour in the head growing. Yeah, bleeding, absolutely. So we've got a bleed that's getting bigger. As we said, the head is a fixed box. Anything that you're adding into that is going to make things worse in terms of the ICP. So tumour, so head injury can do it on its own. Hemorrhage, definitely. Infection, hydrocephalus. So if we've got some obstruction of the ventricles and they're filling up with fluid without draining, then that's also going to increase the intracranial pressure. Cerebral edema, so fluid, and status epilepticus. For the life of me, I'm not sure exactly how that raises intracranial pressure, but I saw that from several sources. So take that as another one that causes raised ICP. And also idiopathic intracranial hypertension, which is, there's no space occupying lesion in this condition. It causes a chronically raised intracranial pressure. And the kind of patients that get idiopathic intracranial hypertension in histories, it's typically young, overweight women. Those are the people that are most at risk of this condition. They'll need a CT head in order to rule out a space occupying lesion or any of these causes. When that's ruled out, what you tend to do, you can offer like therapeutic lumbar puncture, that kind of thing, in order to bring their ICP down. As we said, rule out rule out a space occupying lesion. If you manage to do that, you can do a lumbar puncture, and for management for this, just treat the underlying cause. With a low CSF pressure, it's worse on standing. The kind of symptoms you get: dizziness, tinnitus, brain fog. It typically occurs following lumbar puncture. So usually, a really common cause of this. Having a lumbar puncture done gives you a headache afterwards. It usually resolves. You just tell people to drink more, have some caffeine, and that helps. They may need to have some if it persists, they can have neurosurgical procedures to help with it, but in most people it will be absolutely fine. Due to trauma, then you can get a CSF leak. So battle sign is this bruising behind the ear, extending to the back of the neck. Raccoon eyes is, I'm sure you'll have seen, just sort of looking like two black eyes. You can do a CT to check for a fracture. Rhinorrhea and otorrhea. So if you get a runny nose or things running from the ear, that can be a sign of CSF leak. And there's a really quick and easy way to test for that. The most specific way is testing for something called beta-2 transferrin, but I wonder if you can tell me, if any of you know, or if you can think of a way that you could quickly, if you're in the emergency department, you haven't got any fancy gadgets to hand, you've just got your sort of the usual tests and equipment that you would have in ED. What would be a way of testing to see if somebody's runny nose was down to a CSF leak or not? So CSF is quite high in glucose, or at least it's got a reasonable amount of glucose in it. So what you can do is actually do a urine dip or a BN test. If you take a little sample of that stuff that's dribbling from somebody, then you can check that and see, and if it's got a bit of glucose in it, that's more likely to be CSF than it is just snot. And it's a quick and easy way of determining what you're going to do with this patient who might need to come and see them. Because if you see that CSF, then you're going to be calling the neurosurgeon pronto. Okay, so we talked about this earlier on. Medication overuse headache is something that can be caused by people taking lots of medications to help with their usual headache. So, important thing to note with headaches, they can coexist. So people can have different types of headaches. Somebody can have migraine, but also have a brain tumor. Somebody can have tension headache, but also have a subarachnoid hemorrhage. And it's important to ask, if people are describing two different kinds, it's important to take a history of one and then the other and sort of tease apart. So, okay, so what's your headache normally like? Okay, and this one that started in the last week, tell me a bit more about this one. People that have one of those primary types of headaches, so migraine and tension, typically, things that might have lots of episodes where they need to take frequent analgesia in order to help with it. If they take this analgesia very frequently, so depending on the medication, it's 10 or 15 a month, don't worry too much about that. But basically, by taking regular relief medication, you can give yourself this chronic medication overuse headache. And that's why the prophylactic medications that we talked about with migraine and with tension headache are useful, because they reduce the reliance on acute therapy and therefore reduce the risk of medication overuse headache, which can be really, really difficult to treat once it's present. So can you tell me, we've talked about it, I suppose I've already given it away, that it's basically these are the medications that cause overuse headache. So these are the ones responsible, typically associated. So combination analgesics and triptans are two of the big offenders. So cocodamol, anodin, which is aspirin, paracetamol, caffeine in combination. For whatever reason, using triptans frequently and using combination analgesics frequently is the biggest ones for causing these kind of overuse headaches. Usually resolves after the overuse is stopped, not always. What you want to try and do is minimize the risk before people get to this point. So follow up the people that you diagnose with headache. Medication-induced headache. So can you guys name me some medications that cause headache in themselves? Medications or substances? There'll be plenty of substances that you guys use that will give you a headache. Okay. Just very more to the alcohol there, actually, rather than I'm not thinking about cocaine. But these are the substances that are commonly associated with causing a headache. Caffeine as well, definitely, actually. We'll move on to that in a sec. So nitrates, GTN, dilating your blood vessels, they can cause a reduction in, they face a dilate, they can reduce your ICP. So headache with nitrates is really common. Phosphodiesterase inhibitors, so that's Viagra, also really common. Carbon monoxide, so obviously not a medication that we're giving, but the histories that you tend to get for carbon monoxide are like students or people living in poorly maintained accommodation, and you get people, what you'll get is, if you suspect somebody of having this headache, if it's worse when they're at home, and they get better away from home. So if it was a medical student, they come to work for the day and it feels a bit better, and they get home in the evening and their headache's really worse again. Ask about, do your housemates have similar symptoms? Is there anybody else that you live with? Have they also been complaining of headache? Because if everybody in the house has got it, that might suggest carbon monoxide that's causing it. Alcohol can cause a headache in the acute phase, but also hangovers as well. Cocaine can cause a headache, and histamine too. There's also headaches that can be caused by withdrawing from medication. Caffeine is a classic one, but also opioids and estrogen. Estrogen withdrawal headache is for people that take exogenous estrogen. So we're not talking about people's menstrual cycle. We're talking about, it's people that take the combined pill. Often you'll see people in their dummy pill week or in their week off. They may well have a headache for the first few days of that break week, and then it tends to settle. They start their pills again, and then when they get to start the break week again, they may well have a headache again the next month. Okay, so that was quite a lot of time on secondary headaches. We're going to quickly talk about trigeminal neuralgia, which is the main facial pain that you need to know about. And then we're going to move on to a quick bit of data interpretation and a few questions. It's a lot of information to take in, but what I want you to think about again with headaches is, we've talked about the primary headaches and what they look like. Think about the red flags that suggest other things. That's what I'm trying to get across to you for this presentation. So, trigeminal neuralgia, recurrent episodes of intense stabbing pain, described like electric shocks, and these last a few seconds. So what you're going to see is pain that's coming in and around the eye, but more commonly into the jaw, above and below the mouth. Those mandibular and maxillary divisions are typically where this affects. Most cases are due to compression of the vessels, to vascular compression of the trigeminal nerve. Can any of you name for me the kind of things that trigger trigeminal neuralgia? There's a few like classical activities. Yeah, chewing's one. So it's things like washing, shaving, eating, talking, all things. And it's basically the act of doing it that causes it. If you're eating, as Hasina said, you get pain whilst you're doing those movements. If you stop, the pain will settle down after a few seconds. So when we talked about cluster headache, people like clutching their head and being really restless and banging their head against the wall, they won't be doing that in trigeminal neuralgia, because clutching their head is going to make the pain worse. What they would do is stop doing whatever they were doing, because it brings the pain on, so they will avoid it. In trigeminal neuralgia, they may present with this history, but what you need to do is be aware of other things alongside it, so sensory changes, hearing problems, things like optic neuritis or MS, because there are primary trigeminal neuralgias, so people that get this pain without a sinister cause, but also there can be secondary causes to trigeminal neuralgia. So if you suspect that, if somebody's got one of these red flag symptoms or something that doesn't quite fit, you'd be thinking about an MRI and specialist referral. But the management of the pain itself, carbamazepine is what you use to manage trigeminal neuralgia. So this is a run through of most of the types of headache that we've just mentioned. So we've talked about primary headaches, migraine, tension type, and cluster headache. We've talked about loads of different secondary headaches, and there are loads. There are loads more that I didn't mention because it's essentially small print stuff you don't need to know about or don't need to know much about for your exams. Trigeminal neuralgia, which is a neuropathy, a facial pain / other headache. There's another way of thinking about this as well. So there's loads of different causes of headache, and when taking a history, what is helpful to do is be able to categorize. This is useful from an academic point of view, but a more helpful way when taking a history is to break it down into what's the duration of the headache, how long has it been there for, and you can do that like this. So acute episode, recurrent episodes, and the subacute chronic side. So what we'll do is, what I want you to do is have a think quickly. I'm going to show you in just a second the single acute episodes, or the ones that fit into that category. Oh shit, I've done it already now. So you can see there the kinds of headache that fit into single acute episode of headache. So your strokes, your intracranial hemorrhages, your meningitis, your low CSF pressure, traumas, acute glaucomas, those are all single acute episodes. So the question, have you ever had a headache like this before? They say no. This could be a first presentation of migraine or tension headache, but you also need to be more wary of these kind of things. So I'm not going to click on to the next one now. Can you guys tell me in the chat a couple of these types of headache that are recurrent acute episodes? So you might have a headache and it might be days before you have another one, or yeah, it's a cluster, definitely. More than cluster in that category. Migraine, yeah, absolutely. So trigeminal neuralgia as well is recurrent acute episodes. And subacute chronic, so there's going to be a lot more that fit into this category too. So subacute is giant cell arteritis that I'm thinking of. Can any of you think of any chronic headaches that we've talked about in the massive presentations that I've just been through? So tension tends to be chronic, hypertension tends to be as well. Raised CSF pressure, medication overuse, and brain tumours all tend to fit in this chronic category. So think about, when you're taking a history, that primary, secondary, tertiary headache is all quite academic. This is probably a better way when you're taking a history of thinking about what's going on. Think about the things that fit into acute headaches, what fit into recurrent headaches, what fit into chronic headaches, and that's going to give you a way of whittling down to a certain extent what's happening now. So you can see here, we've got a classic Socrates history, which I'm sure you've seen at medical school many times, with a few of these red flag symptoms that we talked about. These are the kind of things that are going to make you think that something sinister could be going on. It's not to say that having one of these symptoms does mean that. People can have really bad headaches that, you know, thunderclap headache, worst ever headache that isn't subarachnoid hemorrhage and isn't cortical venous thrombosis, and that kind of thing. But these are the things that you shouldn't just be sitting on. If somebody has these kind of symptoms, they need urgent follow-up, further investigation in order to make sure that they're going to be safe. And with examination, the kind of things that you want to do to round off your history. History is the most important thing, I think, with a headache, but examination will give you extra information. So if somebody has a big brain tumour, you may not get neurology, but if you do find focal neurology, that adds fuel to your argument that something sinister may be going on. So do some observations. That gives you a chance to work out what their blood pressure is, for example. If they've got a fever, that could suggest meningitis. Cranial nerves, try and pick up any focal deficit. Fundoscopy, have a look at the back of the eye. It's going to potentially give you some information about whether or not they've got, papilledema that could suggest raised ITP, or if they've got evidence of bleeding that could suggest like hypertension or meningitis, that kind of thing. Peripheral nerve exam, because again, you want to check for neurology and other things, so like neck, temporal arteries. If you feel your temporal arteries at the side of your head, you can feel them pulsating. And in giant cell arteritis, what you tend to get is firm, pulseless arteries. So that is something to check if you're suspecting GCA. Now, I think at this point, we're going to go on to a little bit of information about lumbar puncture. Does anybody have any questions at this point? We've gone through a lot of information there, so I want to just give you a second just to pause, catch your breath a bit. If you've got any questions, please just ask away. Right, in which case we will move on. I'm conscious of the time, so we'll try and rattle through these as quickly as we can. I've got a bit of information about lumbar puncture and CSF interpretation. And then we've got 4 multiple choice questions just to try and round off the session and see what you can remember. So, simply a lumbar puncture is putting a needle between the vertebrae into the spinal canal to sample some cerebrospinal fluid. That's useful because the cerebrospinal fluid can have a lot of clues. If somebody has the kind of symptoms that we talked about in that red flag symptom section, if they've got headache with, fever, or they've got reduced consciousness, or they've got personality changes, or that kind of thing, information that you can get from the CSF can help you make a diagnosis and help you exclude diagnoses. So, in cases of raised intracranial pressure, LP is contraindicated if you don't know what's causing it. You need to work out what the cause of the raised intracranial pressure is. If they have a space-occupying lesion, that can cause herniation of the brain, which is bad news, as I'm sure you know. So, you do a CT in those cases in order to rule out significant mass effect. So that's midline shift, obstructive hydrocephalus, and cerebral edema. Because in those situations, because you can have a space-occupying lesion and you can do an LP, but you need to rule out those things, because those are the kind of things that are going to cause, when you put a needle in their spinal canal and take fluid out, it's going to push the brain out of this fixed box through the foramen magnum, and you're going to get uncal herniation and coning, and you're going to put somebody in a coma. So these are the things that preclude you from doing a lumbar puncture if you see them on CT. If you do a CT, you don't see these things, then you're okay to do a lumbar puncture. Things to be aware of too are if there are anticoagulations. So as we said, you're putting a needle into someone's spinal column. You need to be careful if they're on blood thinners, because you could give them a big hematoma. Skin infection at the site you're going to put the needle in, and unusual anatomy that might make it slightly more difficult or mean that you need to have slightly different considerations for where you're putting the needle. So we know what a lumbar puncture is, why we're doing it, and some of the things to think about before you do it. What about when we do it? So the normal opening pressure is useful because it helps you categorize some conditions. I'm aware of the time, so I'm going to just rattle through these rather than getting you to type up. But as we said about some things that cause low intracranial pressure, raised intracranial pressure. So getting this opening pressure is really important because it can help you work out what might be going on. These are the kind of things that can cause low opening pressure. This one may seem a little bit confusing. Space occupying lesion, as we've said, often causes raised intracranial pressure. This is when, if it's blocking the outflow of the CSF from the head, so if you've got a tumour in the brain that is stopping CSF getting out, that's going to mean that it's artificially low, or is it low at least in the spinal column. So when you're tapping from the spine, CSF pressure seems low, but in the head it's going to be a lot higher. So that can maybe be a little bit misleading. These other things are all as we've talked about before, and as you would expect. Normal CSF pressure, so obviously in a healthy patient you'd expect it to be normal. You can get normal pressure hydrocephalus, which we're not really going to talk about today, but can cause a sort of pseudo dementia appearance. Multiple sclerosis, aseptic meningitis, which is viral meningitis, and lesions that aren't causing a mass effect. Obviously, you'll see a normal CSF pressure, and then high things. These are just some of the main causes. So meningitis, intracranial hypertension, sub-arachnoid haemorrhage, space occupying lesion, all cause of raise. So this is an important differential for when you're doing your lumbar puncture. And then we get on to the different kinds of meningitis. So what I'm going to do is go through them one by one. And then I'm going to show you all of them with a particular attention on the things that make them stand out. So just have a look at this and just try and work through with me these different presentations of CSF for different kinds of meningitis. So with bacteria, you get cloudy CSF, as you might expect. You know, you've seen pus, you've seen things that are infected, they are cloudy and horrible, and that's the same with bacteria. They have polymorph, so it's neutrophils and that kind of thing, rather than lymphocytes. And these cell counts, you can just see compared to normal that you get a lot more cells with bacteria. Glucose gets depleted. This is an organism, it needs glucose to survive, so it starts using up the glucose in the CSF. And you've got bacteria, which is made of protein to a large extent, so you've got a lot more protein in here. Viral meningitis, the tap, usually clear. Lymphocytes are the main cells. These aren't really a living thing, are they? I mean, there's some debate about that, but if you think about them as not a living thing, it explains why plasma glucose is, while the CSF glucose, is essentially unchanged. And again, it explains why there is not much of an increase in protein. It goes up a little bit, it's still less than 1, but it's not to the same extent as bacteria. With TB, it's cloudy. You'll often see fibrin webs. Lymphocytes are the predominant ones. Cell count's not as high as these two. Again, it's using up glucose in the CSF, and the protein can be really, really high. These are big organisms. They tend to have a lot of protein, and it means that result can be really high. And then cryptococcal fungal infection. Again, cloudy appearance. Nothing particularly makes this stand out. This is a difficult one to diagnose often. With TB and with cryptococcal, these tend to be in those high-risk populations. So you'll see it'll be questions will tend to get at somebody with a known history of TB or an immunodeficient patient, somebody who's an IV drug user or is known to be HIV positive or is from sub-Saharan Africa. Those are the kind of people that you should be thinking about TB and fungal meningitis in. I'm going to show you all of those at the same time, and it's going to look very busy. But what I want you to do is just have a look at that yourself and pick out what is the information, because for each of them, except for cryptococcal, as I said, it's quite a difficult one to pick, but each of bacterial, viral, and tuberculous meningitis have something that makes them stand out from the rest, something that's unique. And what you should do for your exams is, if you get a question like this, come armed with the information that's going to set it apart for you. So know that if you've got somebody who's febrile and confused and meningitic, and you do a tap of their CSF and the glucose in the CSF is more than 50% of their plasma glucose, you're going to think along the lines of viral. And if you do a tap and the cell count is 5,000, you're going to know that it's probably going to be bacterial. And if you do a tap and the protein is 5 grams per litre, you're going to be thinking about TB. Use those unique identifiers to help sell an answer to you. So these are the kind of things that I'm thinking of. You do a tap, there's something for each of bacteria, viral, and tuberculous meningitis that sets them apart from the rest. Cryptococcal is difficult to tease out. There's nothing that makes it unique, but the history in the question should help you come to that kind of conclusion. Also, this is rare in people. So again, I think HIV is something more for your specialty year, but your CD4 count matters to what diseases you can get. Fit, healthy people don't get cryptococcal meningitis. The people who get cryptococcal meningitis have got a CD4 count that is through the floor. They've got like almost no CD4 lymphocytes. So basically, cryptococcal meningitis is in people who are HIV positive and also not taking their antiretroviral medication. If you've got someone who's HIV positive and is taking their HIV meds, then they're not at risk of this. This is only for people who are not adherent to their medication. So that's the kind of thing that's going to sell this for you. These ones, you'll get history, but you've also got some stuff from the data that's going to make it stand out to you. Does anybody have any questions about that? Because I know that's, again, quite a lot of information to go over in a short space of time. No, okay. So we're going to go through 4 multiple choice questions quickly. Can you guys go to Kahoot on your device, please? And I'll get this link up. I'll give you a second to jump into that. Right. 8 out of 14. I think we'll just get moving, guys, because I know I've taken a lot of your time already. So hold on. I apologise. I've already jumped the gun. Can we try that again? Sorry, everybody. Please use this new game pin, and then I won't press start until we've actually seen the question. Thanks, guys. Nine, 4, 5, 1, 6, 3, 3. Right, that's 8 people again. Right, so we'll quickly look at these questions. So question 1. A 28-year-old man from Zimbabwe presents to the emergency department with a 2-week history of fever, cough, headache, vomiting, and neck stiffness. He is known to be HIV positive and is on treatment. His most recent CD4 count was 450 cells per millimeter cubed. On examination, he has no focal neurology and appears drowsy and confused. You suspect meningitis and perform a lumbar puncture. The results show the following. What is the most likely diagnosis? So, if you can think back to that table that we've just looked at, think about the history of the man that's coming in, and then look for unique things in his TAP results that could point you towards one thing or another. He's HIV positive, so he's at risk of all of them. Just because it makes TB more likely doesn't rule out bacterial or viral. He's at more risk of any kind of meningitis. So, what from the TAP points you towards a diagnosis? And now we'll start, if that's okay. So you've got that question. You'll have 10 seconds to put your answer in. I'll talk about why the answer's right as well in just a second. But TB. Okay, so it's a bit unfair of me to do this with the fact that we're overrunning. So let me go back to this quickly because I know that we can tab over here and see if you got it right. Okay, so the reason that it's TB is because we've got a CSF protein that is pretty high. He has got lymphocyte predominant. So if we go back to this, he's got lymphocyte predominant. So it basically rules out bacterial. We know that bacterial has polymorph predominant. It's got a cloudy appearance. Viral can be cloudy, but it's usually clear. So we're thinking more probably TB. The cell count, it fits in the range for both of those. There's nothing really that makes it suggest. The CSF glucose is less than 50% of the serum glucose. So if we look back here, that fits with TB and with bacterial. So Viral, it doesn't fit with viral there, and the protein as well is 3. We know that TB can be really high levels of protein, so there's a few different things here in combination that suggest that TB meningitis is going to be the most likely cause. I think if I gave you cryptococcal, it would have been perhaps a lot harder to tease that apart from TB. The clue there was the fact that he's on treatment and his CD4 count is good. But the reason that this is TB rather than viral or bacterial or normal is that there are subtle indicators that rule out this and this and this. I mean, obviously, you all know it's not normal. But just know those differentiators really well. Know that you don't have to know this table perfectly, but know that bacterial polymorphs is the predominant cell. The cell count can be really, really high. Know that viral tends to present, certainly in exam questions, with a normal, it hasn't depleted the glucose in the CSF. And with TB, know that fibrin webs and this sort of high level of protein are things that are like the hallmarks of that when you see it. So the answer to this question is tuberculous meningitis. Question 2. Sandra is a 64-year-old female brought to her GP by her daughter due to progressively worsening headache over the past month. The headaches are unilateral and throbbing in nature. There are no visual disturbances. However, Sandra reports nausea and sometimes vomiting with these headaches. Her daughter comments that Sandra has recently become more moody, aggressive, and has started playing online bingo every night. Sandra has a history of childhood migraines and she takes no regular medications. On examination, her pulse is 60, BP 130/85, respirate 16, afebrile, no focal neurological deficits in the face, upper limbs, or lower limbs. What is the next most appropriate step in management? Regular paracetamol and follow up, regular propranolol, metoclopramide as needed and follow up, routine imaging or urgent imaging. So this is a typical kind of question that you could get in your exams, is looking to see about your diagnostic skill, not necessarily your diagnostic skills, but how safe are you? How confident are you in the diagnosis that you've got? You've got a lot of information here that could point you to a diagnosis. Is there anything that would make you consider something else? What is the best thing to do in this situation? Okay, so let's go back to the quiz. That's Sandra playing online bingo. Yeah, good. Urgent imaging. So, who's to say why Sandra's become more moody, aggressive, and started playing online bingo every night? It could be that it's lockdown and that's what everybody's doing at the moment, and there's nothing to be worried about here. But those personality changes are a red flag symptom and they should be investigated. She's an older woman. She's got those personality changes are a red flag. She's an older woman, so could fit the demographic for a brain tumour. The rest of the history could all fit with migraine. She's got a history of migraine. Her OBS are perfectly normal. She doesn't have focal neurology. It's a unilateral throbbing headache, and she has nausea and sometimes vomiting. That all sounds like migraine. The thing that you need to be aware of is that these personality changes are a red flag, and red flags mean urgent investigation, because if she's got a brain tumour, that time is going to make a difference. Routine imaging is not a bad answer, but because we're trying to rule out a brain tumour, you're thinking 2-week wait, you'd get an urgent MRI brain, and then use the results to refer on to a specialist. Okay, so let's have a look who got that right. Very nice. So, question 3. A 35-year-old gentleman presents to his GP complaining of pain, which comes and goes on the left side of its face. Pain comes on suddenly, feels like an electric shock, and lasts for a minute or two before terminating. He's noticed that it's typically brought on by shaving and brushing his teeth, but sometimes happens spontaneously. He's had this pain 8 times in the last month. He has also noticed that he's having difficulties hearing from his left ear. On examination, he has a moderate degree of sensorineural hearing loss in his left ear. What is the most appropriate step in management? A. Carbamazepine, follow-up. B. Subcut sumatriptan and follow-up. C. Routine referral. Or D. Urgent referral. So, again, have a think about what the diagnosis might be, but also, even if you don't know the diagnosis, what's going to be the best thing to do in this situation? One of the key things to get across with headaches is that because there's so many different presentations, so many to know, it's not necessarily about diagnosing headache every time. That's not what happens in the real world. Often making a diagnosis of migraine in GP, I've just been on GP for my job. Headache isn't necessarily something you diagnose on the first presentation. People will often make a diary, keep coming back, representing, but the things that you should pick up are red flags and the people that need to be investigated urgently for something more serious. So bear that in mind when answering questions like this. Okay, so mixed bag. 35-year-old gentleman presents to a GP complaining of pain, which comes and goes on the left side of its face. So, could be a few different things at the moment, couldn't it? Comes on suddenly, feels like an electric shock. Now, that's something that I mentioned with regards to trigeminal neuralgia. Lasts for a minute or two. That's trigeminal neuralgia. Cluster headache, which this would be the treatment for, is unilateral, does come on suddenly, but it lasts an hour or two. This lasts like seconds, up to a minute or two. So this is trigeminal neuralgia. It's brought on by shaving and brushing his teeth. Again, if it's trigeminal neuralgia. Jaw claudication, could be GCA, but you'd be expecting that from chewing. And the headache from GCA lasts longer than it does in the case of trigeminal neuralgia. 8 times in the last month. So this is recurrent episodes. We talked about that history. Recurrent episodes fits with trigeminal neuralgia. So this is absolutely the right answer. You would prescribe carbamazepine to this person, but we're looking for the single best answer here. And this doesn't account for the fact that he's got hearing difficulties and has sensorineural hearing loss in his left ear. So that's going to be making you think about secondary causes of trigeminal neuralgia. So you do want to prescribe carbamazepine to help relieve him of symptoms, but if you're only going to do one thing here, the safest and best thing to do is urgently refer. So this is a red flag symptom. He's got hearing difficulties. That could be a brain tumor. That could be an aneurysm of one of the blood vessels that supplies the trigeminal nerve. Something is causing this pain because it's also seems to be causing this sensorineural hearing loss. So we're going to need to do an urgent referral and get him seen in order to make sure that he's safe and he's not got anything that's being undiagnosed. So let's move on to the last question. 33-year-old man is admitting to the medical unit with a severe sudden onset headache associated with vomiting and neck stiffness. He has a history of recurrent migraine, CKD stage 4, autosomal dominant polycystic kidney disease, and early onset hypertension. His observations and bloods are currently stable. He has a CT head, which is reported lastly, hyperattenuated areas surrounding the circle of Willis and interpeduncular fossa, no obvious skull fracture or parenchymal hemorrhage. Ventricles are normal size and there is no midline shift. What is the most likely diagnosis? So, again, it's a lot of information. It's a wordy question. Have a look here about what is the history trying to point you towards. Sudden onset, severe headache, vomiting, neck stiffness. He's got a history of recurrent migraine. He's also got a history of CKD and polycystic kidney disease and a history of hypertension. His observations are normal and his bloods are normal. So, of these four, use this information to rule things out, cross things out based on this information. The cover test is a great way of answering SBAs. So if you didn't have any answers there in front of you, what would this make you say? If you see that, great. But the next best way, if you're not sure, is just cross out, give yourself a better chance of guessing the answer if you don't know it. So use this information to cross stuff out. And let's tab over to this question. Last one, 4 of 4. Sub-arachnoid hemorrhage, yeah. So, again, I've given you a lot of information to process today. So, with subarachnoid hemorrhage, he's got lots of risk factors. High blood pressure and polycystic kidney disease. This is a big risk factor for berry aneurysms, as we talked about, and hypertension puts them at increased risk of rupture. He's got a sudden onset severe headache, and he's got vomiting and neck stiffness. That all fits with subarachnoid hemorrhage. Migraine, sudden onset and severe neck stiffness. Neck stiffness, we can cross migraine out. It doesn't cause neck stiffness. You wouldn't see meningism. Meningitis, his observations are normal. He's not febrile. He's not tachycardic. Meningitis, we can cross that out. Subarachnoid hemorrhage and cortical venous thrombosis. It could be either. This is a more typical history, and he's got the risk factors for subarachnoid hemorrhage, but it could be cortical venous thrombosis. And then the CT head tells you that you've got hyperattenuated areas surrounding the circle of Willis, which is basically this, what we saw earlier on. This is hyperattenuation, this is fresh blood, this is bleeding into that, that space. So there are clues here that make everything else impossible. So the answer is subarachnoid hemorrhage. We'll cover a bit of exam technique each time that I present to you guys, but have you guys got any questions about anything that we've covered in the presentation today? I'm going to leave that there, and we'll just quickly go across to this and see who's finished top on the podium. Ali, nice work. Good job. 4 out of 4. Good work, Jess. Very nice. Okay. So, if you guys would do me the favour of just having across and filling out some feedback for me, that would be really helpful for me. If you have any questions, please stick them in the chat now, and I'll be happy to answer them for you. Is there anything that doesn't make sense? anything that you want to know a bit more about? Any resources that you want recommending? I think that Nice CKS does a good job for some of these of showing you what kind of things that you should know in a very literal way. So the guidelines for migraine and for tension headache are very good for showing you how you should treat it in a stepwise approach. It's slightly more difficult to make out for other conditions. So a lot of the secondary conditions, you've got loads of waffle in there. But for migraine and for tension headache, the Nice CKS guidelines give you a nice set of diagnostic criteria for your history and gives you a nice stepwise approach to managing the conditions. The Oxford Handbook, if you've got it, is good for just looking at like a general approach to headache and taking that history. Socrates is really good for any kind of pain. Socrates is a good way to go about it. And when you start taking that history, keep it open and think about what duration of headache you're dealing with, because that's automatically going to help you work out what might be going on. Think about the location, because some of them have different locations, and think about the duration, and just let the history, let the person telling you just spell out to you what kind of headache they've got, because it'll all become apparent with just a little bit of questioning. Okay, guys, we're gonna stop that there. Thank you very much for listening to me tonight.